Welcome to Planetary Health First, Mars Next. It is awesome. We have an amazing special guest in the studio, and I am just super impressed with those glasses. That's super cool.
It is the best part of what I have to offer, the glasses.
All right. Well, that he's modest too, so I love
It's
the modest.
downhill from here. It's downhill.
Yeah, all the way downhill. Anyway, well, let's go uphill. Let's turn that around. But anyway, we have here today Dr. Craig Joseph, and he is currently serving as the Chief Medical Officer at Nordic Consulting Partners. He's also been an interim Chief Medical Information Officer, and that was in Seattle Children's, and he served multiple roles. I love the HIMSS. He's been very involved with that. But he's also written a book, and you can't really see it too well there a little
There you
bit
go.
because of my the virtual screen, but it's Redesigning for Health, the Human-Centric Approach. And we all could say amen to that because healthcare just needs a lot. So we're super glad you're here. Take it away. And I call you Craig today, right?
It's either Craig or Your Honor or Your Highness. I go, but most people choose the first one. So yeah, Craig would be great. Yeah, I'm happy to be here. Like you said, I'm a physician. More specifically, I'm a pediatrician. Practiced primary care pediatrics for about 9 years before moving to the more techie side and going to work for a large electronic health record vendor. And since then, I've been chief medical officer or chief medical information officer at a number of organizations. And wrote this book or co-wrote this book with a colleague of mine, really in response to seeing what folks are doing in healthcare, pretty much everywhere, but in healthcare specifically, about how we build these tools, we build technologies, we build workflows. For people to do things. We want doctors to do certain things. We want patients to do certain things. And often they don't do those things and we wonder why. And sometimes it's because we're actually we're designing away the ability for folks to do the right thing. We want to make it easy to do the right thing, yet we put obstacles in their path, and then we wonder why they don't do that right thing. So this book is really a call to action, to stop trying to get in our own way and just acknowledge there are certain ways that humans think. And this used to be more of a subjective field, but really it's become a lot more science focused about, how we as animals function and interpret our environment. And if we can go with the flow, it's much easier to get people to do what we want them to do.
Awesome. Well, we're going to just kind of go through some really high level points and almost like a speed round, if you will. I'm going to just throw something out there. The high price of privilege. And all these notes and references are from the book to my audience out there.
Yeah. So this was so before every chapter, we start off with a little short vignette or story about putting in practice the design principle that we're about to talk about. And with that, the high price of privilege, we're referencing what often happens is when a VIP or someone important, someone whose name we all maybe know, goes to the hospital. Oftentimes, the hospital leadership, everyone wants them to be treated by the best. They need to get the best treatment from the best physicians and the best unit. And sometimes the best physicians are the ones who are the most senior. They've been around the longest. And what curiously happens, and this has been shown in a few studies, is that sometimes the best really aren't the best. Why? Well, because they've been practicing for a long time, and they're now at the level where they do a lot of other things besides practice. And so they have leadership responsibilities, they have research responsibilities, they do other things. And so sometimes you're like, well, I need this doctor. This doctor is the best. Well, actually, she doesn't really understand how the hospital works anymore. She did. But she doesn't know that, if she orders this test, it's actually not going to come back for 2 days. But if she ordered that other one, which would probably give her the similar information, it would be back overnight. And so what they've shown in a couple of studies is that VIPs who are trying to get the best treatment, either they're doing it or someone's doing it on their behalf, often because they're VIPs, their treatment isn't as good. And so I think the moral of that story is, kind of just going with the flow and not trying to get special treatment sometimes is the special treatment that you need.
Yeah, I love that. I think of like the community health worker with the social determinants of health. So many of the things the social worker is the best, or the case manager rather than the doctor. Nothing against doctors or nurse practitioners, but if you need resources or to do a Medicaid or whatever, the people on the ground that have that. So you're totally right. Like probably a different level workers. So love that.
Well, it's a team. One of the things we try to emphasize in the book is it's a team sport. Healthcare is a team sport, and we sometimes think of it as just it's the doctor. They kind of really hit home for me when my wife delivered our first child. We had a nurse that worked with her for 5-6 hours almost straight, and then the obstetrician jumps in at the very end and takes all the credit. She's like, boy, the nurse really did 95% of the work, and the doctor's there at the end. It's a team sport, and without the entire team, it falls apart.
Yeah, I totally remember that myself. It seems like they just came at the very end, just to sign off on the thing.
Get all
the baby
the glory.
Was out. Yeah,
yep. Like get all the glory.
Yeah, the team had already won, and they were just going to do the end like minute talk. But anyway, the Heavenly Help Desk. Does that tell me about that?
Again, one of the design principles that we talk about is transparency, trying to make things transparent so that folks really understand what's happening. I reference a help desk that one of the jobs that I had, it all really started. I was maybe at this job for 2 or 3 weeks, and I went to the restroom, and there's a sign on the restroom that said that one of the toilets had overflowed and a help desk ticket had been assigned. And I thought it was a joke, actually. I was working for a software company, and I thought, well, this is kind of funny. I was looking around, are there cameras around? What's going on? Who would submit a help desk? We all submit help desk tickets because our computer's broken or because email won't work. But at this place, you could submit a help desk ticket for anything, really. If you saw that there was a crack in the sidewalk and someone might trip, you could submit a help desk ticket. And what I really thought was heavenly about this system, it was pretty basic, but it followed those laws or the rules of transparency. In that, I could give the information that I knew. So if there's a crack in the sidewalk, I could tell you where the crack was, but it didn't require me to give information that I didn't know. So often when you're trying to get help from a company or from your own company's service desk, they'll give you 5 or 6 questions, and half of them you don't know the answer to. And a reasonable person, maybe they need it, but you don't know the answer, and you're required to put something in there. And so sometimes you guess, and sometimes you give them garbage, which actually slows them down. One of the benefits of this particular help desk ticketing system that I was working with is it said, hey, to solve your problem, it says you're having some email problems. Okay, to solve your problem, here are 6 questions we would really like you to answer. If you know the answer, please give us those answers, because it'll help us expedite your resolution. If you don't know the answer, that's fine too. We'll figure it out, but it's going to take a little bit more work. We might have to call you. We can't just fix it behind the scenes. And I thought that's really a great way. Why do sometimes we design workflows, technologies, systems whereby we give you a hard stop. We say you can't go any further unless you give us this information. And if I don't have the information, or I forgot the information, I'm either stopped in my tracks. I can't ask for a fix or help, or I have to give you garbage, which is, will let me get past that hard stop, but doesn't really achieve the purpose. And so you see that when you're dealing with health insurance often, or when you're trying to make an appointment. Sometimes if you're doing it online with the doctor's office or a hospital, you don't know some of that information. And it seems silly to not let you kind of progress. You're going to have to call someone. It's going to take more time for everyone.
I'm thinking just you almost penalize the person before they even enter to help. It's like you already like demotivated them by that design. It's like just they're trying to do the right thing, and you're like, well, you're already not qualified. It's like, you're making the friction. Oh my gosh. So I totally
you're adding friction. But what's ironic, and of course we want to reduce friction for things we want people to do. Sometimes we want to add friction for things we don't want them to do, and that's completely fine. But yeah, adding friction not only for, I think one of the things we try to point out is you're not only adding friction for the person who's seeking help, but you're also adding friction for on the other side for the folks, the technicians or whomever's dealing with that issue, because now, wait, did they just say this to get past that stop, or did they really mean this? And now I got to do more work. So it benefits no one.
Yeah, it's like doing the application process for whatever. You'll at whatever point to get through the checkoff, people put in whatever they need to do. So
like
data dump, crap in, crap out. So getting rid of stupid stuff. What a great segue.
Yeah, well, that is the title of one of the chapters, and in fact, we had a reviewer who's like, "I don't think you can, say this. I think this is kind of rude." And when we pointed out we're actually referencing a New England Journal of Medicine article, then I was allowed to say that some things were stupid. So, getting rid of stupid stuff or gross was the title of an article, and basically it was the chief medical information officer at Hawaii Pacific Health several years ago said, "Hey, we want to know, are there things that are dumb in our electronic health record?" And she was focused specifically on that. Are we asking you stupid questions? Are we requiring you to jump through hoops that don't make any sense to you? If so, tell us. And that's not that uncommon. What is uncommon? So it's not that uncommon to ask people, for feedback. What's uncommon is that they did something about it and they were transparent about it. So basically, for every single person that submitted a suggestion, they got back to them and said, "Hey, that's right. That was a mistake. We shouldn't be asking nurses to document the status of the umbilical cord for a 6-month-old child," right? Now, as I'm a pediatrician, that's a perfectly good question for a 7-day-old. Like, "Hey, has their umbilical cord completely fallen off? Is it, are there any signs of infection?" That's a great question. However, that question makes no sense at 2 months or 4 months or 6 months of age. And somehow a mistake had happened and people were still documenting on that. And it only took them 2 seconds to go, "It's fine." But it was a dumb question, and it kind of made people a little bit sad every time they had to answer it. So she got rid of those things. Some things, though, that people submitted as stupid stuff actually wasn't. They just didn't understand that this is a regulatory requirement, some law that says we have to collect this information. Or, hey, you actually may not know how we're using this information because you're not using the information today. But it's really helpful a year from now when we look back to be able to see, hey, did the patient progress from that point to this point? And so sometimes the information we're asking for, go on. Yeah.
When you're saying this, it makes me think always, why can we just communicate why to people? If you give them the why, I think they'd be more likely. And that seems, and I guess with regulatory and, all the, with healthcare, they don't want to tell you. Maybe they don't want to let you know. This is real. Yeah.
Yeah. Sorry. No, I think you're 100% correct. The why means so much to so many people. And I don't think we hide it. I don't think anyone's purposefully hiding it. It's just they don't think about it. Or if I'm designing some tool or some workflow, and I've been doing this for 20 years, it's just so obvious to me that this is what this would be. And it's obvious to me because I've been doing it for a long time, but it's not obvious to everyone. And that's something that we as humans kind of, I think, overlook fairly often. And the why makes all the difference. To your point, I've certainly been, asked to go in front of large groups of physicians who are upset. As an aside, I used to tell my children when they were small and I was going on a business trip, they asked me where I was going. And I said, "Daddy's going to get yelled at by doctors." Because that's kind of what I did for a living. But oftentimes you could diffuse that by saying, "Okay, well, let me explain to you why this is the case," right? We don't like it this way. Well, let me explain to you the 3 other options, because there were options. Let me explain to you. "Oh, well, those are all worse than this one." And I'm like, yes, they are. Yeah. So really you're asking for the best option. There really isn't a great option, maybe, because of the technology or for whatever reason. So we gave you the least bad option. And then people are much more understanding, to your point, when you explain to them why. No one's here to tell you that it's great that we have to jump up and down for prior authorizations with insurance companies. But that's the reality. So at least today, that's the reality. So how can we make it so it's the least bad solution? You're asking me for a good solution. I don't think that exists, maybe, but the least bad solution is what I can offer you. And as long as you agree with me that it's the least bad and that it's required, then you're a little bit happier, and I survive another day.
Well, this is great. I really think we need to move on to another topic, that's the ecstasy and the agony of technology.
It's a love-hate relationship that many of us have, not just in healthcare, but in life with technology. Our cell phone's probably the greatest example. I love my cell phone, and I at times hate my cell phone, and that's the point that we're trying to get across in this chapter. That it oftentimes is the double-edged sword, right? I need technology to do my job as a physician. It's really very difficult, if not impossible, to do it the way we did it 15 or 20 years ago with paper. You don't really see paper very much anymore. And if you do, it's kind of just for a limited purpose, and just kind of in a small clinic somewhere. But typically, we need technology, and it's great when it helps us. It's awesome, and I'll give you one example. I remember when it was difficult and it still is to some extent, but it's difficult to get information from one hospital system to another, or from one doctor to another, especially if they're using different electronic health records or different technology stacks. And that was almost impossible. What we really did is we printed stuff out and we faxed it over, and then we scanned it back in, which is incredibly dumb, but that's what we did, and that's where we're still at for some reason. And doctors are like, we need all the information. I had many conversations with physicians like, we need this technology, we need all the information, because they needed some of the information. Now, fast forward 10 years, and now they're getting access. If I'm at hospital A in New York, and I need to get information from a hospitalization that the patient had 5 years ago in Florida, sometimes, depending on the technology today, I can get access to the entire admission. Like, I can get access to every lab result, every progress note, every radiology exam. It's all right there. What quickly happened is I had physicians saying, you have to stop this. I can't have all this information. It's information overload. Mm-hmm. And that's technology right there. That's the agony and ecstasy. I love it. I could find the information that I needed. I hate it. It's too much. And now I'm responsible for knowing everything that's in there, and I can't really be. So yeah, it's that dichotomy.
Yeah. I love that. It's like, we're so relieved with the in and out menu. It's just like trying to buy a pair of shoes. I mean, I know you and I probably in the same generation, maybe, who knows, it doesn't matter, but I'm sure you and I can relate that when you went and bought sneakers when you were a kid, you didn't have to worry about 70 SKU. I mean, 100, who knows? But anyway, it's refreshing for simplicity and design.
Yeah, and that's the way many, not all, but many humans are set. Hey, I can't. I'm overwhelmed with 20 choices. Please give me 3.
Mm-hmm. The stupidity of not listening to your real experts. Tell me about that.
Yeah, it's just a problem that I see over and over in healthcare, especially with technology projects, but pretty much with anything. If we're putting in a new system or trying to design something for the cardiology department, often who do we go to? Who's the ultimate expert on how that thing should work or what problem we're trying to solve? Well, we go to the chief of cardiology, the department chair, or someone like that, and interview them and spend time with them and try to get really to the bottom of, hey, what problem are we solving? How are we best going to solve it? We do a great job of getting all that information, of putting it into action, tweaking all the configuration settings behind the scenes. And then what happens? The project fails. Why? Well, that cardiologist was one out of maybe 40 cardiologists in the department. And he or she, the way they wanted it to work wasn't actually the same as the way the majority of the cardiologists think or work. Why? Kind of talked about it a little bit earlier. Sometimes leaders, they practice 1 half day a week. And when they do, they have fellows and residents and all kinds of people are surrounding them, helping them, and their needs and desires are a little bit different often than the regular folks who don't have all of those privileges and don't have all of that help. And so it's really important from a design perspective, if you're creating something new, to make sure that you're talking to the right people. And so sometimes it's not the first person you talk to, and sometimes you need to talk to a bunch of people to figure out, like, okay, now I see how this is really going to be used day to day, not the special. You never want to design something for a special case. If that special case is going to be an infrequent occurrence, right? You want to go for how is the average user going to do this? What are they thinking? What are their problems? How will I solve them?
Seems like we're segueing right into this. Start with the end user in mind. Like, who in the heck cares about it and will be using it?
Right. Well, what am I? Oftentimes when we start a project, we're trying to think of, hey, what problem are we trying to solve? Right? We are trying to solve this problem that there's a research study going on and I don't have some of the basic information, or patients are coming to my emergency department and they're leaving before they're being seen because the wait is too long. And what's the specific problem? And we focus on that to the exclusion of, well, who's going to be the one helping us solve this problem? And by excluding them, using some assumptions that, hey, well, I know how the emergency department works. I'm a pretty smart guy. Well, maybe that's true, or maybe I knew how the emergency department worked when I was a resident in a different city at a different hospital at a different time, but I don't really understand the peculiarities of the end users at this place. Or I understand exactly how the emergency department works where I work. I work in an inner city big academic medical center, and I've got lots of support. But now I'm designing a tool that also needs to be used in a small rural emergency department, with one doctor and two nurses and one technologist, one lab tech and one radiology tech. Completely different situation. And so not taking those things into mind when you're designing the tool or workflow or technology, it can be a big miss. So if you got to really understand who the end users are, and make sure that their needs are being addressed so that you can solve that bigger problem.
Digital purgatory.
Yeah. So this kind of describes where we give you some kind of tool that helps a little, but doesn't make it all the way. And this can be a big problem because the expectation of our end user, whoever that might be, it might be a patient, it might be a doctor or a lab technologist. The problem is that they're looking for us to solve this big, ugly, hairy problem, and we get them halfway there, and we're like, well, this is better, right? And so they're happy that we're paying attention to them, but we didn't actually solve their problem, either because we didn't have time, money, resources. We run out of that, and so and I think that's fine. It's fine as long as you are transparent and, again, something that you mentioned earlier, communicate. Are you communicating well, right? So if we tell them, like, hey, totally understand this is you're at point A, we want you to get to point D, we're going to be able to get you to point B right now. Mm-hmm. That's not going to solve your problem, but we're working on getting you. We think C's coming and then D will be there. And with a purgatory, often we forget that we got you to B, and then we go on to the next place because it's really hard to get you to C. And then we wonder why you're upset when we come back to talk to you a year or two later, because we kind of implied or promised we were going to get you to that solution, and we never got you there. And you're stuck in this, well, it's a little bit better, but it's not that great.
I love this one. I think this is a great motto for life anyway, with make it easy to do the right thing.
It's, again, kind of, I talked about this at the very beginning. It's amazing when we want folks to do something. And again, when I say I want you to do something, I want you to pay the copay. I want you to take your medication on time. I want the physician to order this or to document that. Why? Hopefully because that's going to help make the system run better. It's going to help the health of the patient. So we've got these things where we're like, that's the right thing to do. We've all established the right thing to do is to take your medication on time. The right thing to do is to order this inexpensive test as opposed to this expensive test, if both of those things will get me the right answer. Yet we make it difficult for you to do that thing in the system, right? So, oh, well, we want them to order this particular CT scan. Well, how? Okay, well, first they have to go to this box and then they have to type in exactly this. But if they miss it by a letter, it's going to totally not work and they're not going to be able to find the thing. Or, we want the patient to take the medication, but they have a very high copay and they're not going to be able to afford it. Or there's no pharmacy in their area, or it's always closed whenever they get off of work. And so it's not convenient or even possible for them to get it. And so I think part of that design process is trying to make it easy to do the right thing. Step number one, find out what the right thing is. You have to know what the right thing is. But step number two, okay, now let's take the friction away, as much friction as we can, to make it easy to do that. And I think the converse is also true. Make it slightly difficult to do the wrong thing. So we do this kind of try to follow this principle all the time when working with electronic health records. We want to be able to say to physicians, hey, you're the doctor, you're in charge. Ultimately, you can order whatever you want to order and document whatever way you want to document. You're the boss. However, we think that most of the time, 90% of the time, it's going to be option A that we think that would be better for you. Options B and C are still there, but option A is almost always the way to go. We want to, how can we help with that? How can we make that easy to do that? Well, we want default option A, right? So when I open up the order set or whatever tool I'm using, the right answer, the best answer is just defaulted. So I don't have to do much thinking or doesn't involve very much muscle memory. If I have to change it every single time, at some point, I'm just going to be like, it's not worth it. I'll just choose this other more expensive test. Well, that's not good. And so, again, trying to make it easy to do the right thing and slightly more difficult to do the wrong thing. Acknowledging when I say wrong thing that's the wrong thing for most patients, but there are going to be some patients out there where that is the thing you need to do. So I need to make it possible for folks to do these things, but acknowledge that that's not the common route they're going to go down.
I think the design thinking is really cool with everything, with location. I think you like, I remember seeing a Netflix series with Peter Thiel, the venture capitalist. And now whether this is real or not, there was no furniture and he just didn't want to make a meeting long, and this is just sort of random, but he just, the moment you sit down is like making it easy to stay longer.
Yeah.
It's funny. It was the craziest thing. It was a Spotify Netflix series, and it was really kind of, that guy's, most of them, when you're a billionaire, you can afford to be out there, right? but that's the design thinking, like,
perfect.
Yeah,
it's perfect. And he's not the only one. I remember seeing I think it was a 60 Minutes on I don't remember which Secretary of Defense, but in his office there were no chairs when he was meeting. So in his conference room or wherever he met with his with the generals, and so you knew that when you were coming, you wanted that meeting to be as short as possible. You cut right to here's the situation and here's the resolution and how are we going to get to it as fast as possible. I think that is design. I think that's 100% right. You're designing sometimes by, it's not necessarily including something, but by excluding something. In this case, a chair. It's brilliant. I would not want to go into such a meeting, but I totally understand.
Yeah, that's the other thing. Like, get to your pitch. I don't have more than 3 minutes. That's it. And so I love this topic, the innovation safari.
Yeah, so certainly not my concept. And we kind of stumbled onto this when we were interviewing Lyle Berkowitz, who's a physician and entrepreneur, or as he calls himself, a physician-preneur. I don't know. He combined those two words. It made a lot of sense. He started a bunch of companies and has been quite successful. And one of the things that he talks about from an innovation standpoint, a success standpoint, is taking folks and getting them out of their comfort zone. So if you're a hospital executive or physician leader, removing you from healthcare and taking you across town to a factory or a manufacturing spot, something where you really don't know anything about how that place works, and seeing how they have innovated. What have they done? Is there some aspect of the way that this factory functions that is relevant to your hospital that you could kind of take back and learn that lesson? And at first blush, it sounds like that's kind of crazy. A hospital and a factory are very different things. But it actually kind of makes sense, if the way that, a hospital has to sterilize instruments, for instance, and the way that instruments get sterilized before they go back and are used in a different operation, and how they travel, that is absolutely relevant to how factories do very similar things with, you can imagine, sterilizing food products, or the containers for food products. And so, the idea of learning how other industries do something, and then taking some of those lessons back to your industry. Certainly, healthcare's learned a lot from air travel and air traffic control, and their safety mechanisms, and how do they go to try to drive to zero events. Of course, they never get there, but they've done a great job, and part of it, again, we've said this word many times, is transparency. In air traffic control, whenever there's a problem, everyone writes up a report, right? You don't need special permission, and you can learn from that, take that back to your quality program. Well, when we have an infection that we don't expect for a patient, or there's some sort of mishap in the operating room, how do we make sure everyone heard about that, find what caused it ultimately, and make that as unlikely to ever happen again as possible? And that's that Safari.
Yeah, no, I like that. And I quickly thought of Elon Musk when he was, in the center of Tesla. And I know he's highly controversial, but he was, just put his desk right in front of the factory in the middle of it. And even though that's a little more than going to a different industry, but I think as an innovator, it's really fascinating how there's so much of a collaboration from the aerospace that he was learning, and then putting that knowledge also from, all his different industries. And I think that's another thing that probably makes him a superpower, just one of the reasons he is so successful is all that borrowing from those, scaling and practices, and then cost control. So love your reference with the Innovation Safari. And I love that. What was your why? Probably could have asked that in the beginning, but tell me what got you kind of really going down this rabbit hole and excited to write this book.
I read several decades ago, I read a book by Don Norman called Psychology of Everyday Things. And subsequent editions have been put out as Design of Everyday Things. And one of the very first chapters he talks about, this has nothing to do with healthcare directly, but one of the first chapters he talked about was doors. And in fact, now sometimes folks call these poorly designed doors, they call them Norman doors, because Don Norman's the one that pointed them out. If you ever see a door that has instructions as to how to use the door, it's probably a poorly designed door, right? That's the theory, right? And so if you see a door that has a handle on both sides, well, one side you're going to pull and nothing's going to happen, and the other, and the opposite is true on the other side. So it's really a guess as to how to use that door, or someone will write the word pull or push on it, and so then you'll have to read the directions to the door. And when that was like an aha moment for me, like, wow, you shouldn't need directions to learn to use it, to understand how to use a door, because we have affordances, we have ways of telling you, hey, if there's a flat plate on a door, you're probably supposed to push there, flat metal plate, push, handle, pull. That's just no one's taught you that. You didn't learn that in first grade. That just seems to be the way that the world works. And so why can't we apply some of those lessons to healthcare, again, for patients, for clinicians, for operations folks at hospitals and offices? Why can't we learn some of those things and say, like, yeah, why is this thing so complicated? Couldn't it be, boiled down to be much easier? That was the why. That's why we started to write the book, and also seeing seeing either mistakes that we had made or that clients when we were consulting had made, repeated over and over and over again, and them and us not understanding why it wasn't working when it was pretty clear ahead of time that it wasn't going to work very well.
Now, is this book, I know there's a heavy information technology play on it, but it's universal to the whole experience within healthcare.
Yeah, the goal was to use technology kind of throughout to kind of give some of those examples, but also to understand how this is somewhat technology focused, but certainly has applications far outside. One of the examples I give at the beginning of a story that actually happened to me was a patient who, when I was practicing pediatrics, I had a small child who diagnosed with asthma, and had to get them. Ultimately, they needed this patient needed a machine, a nebulizer, which kind of makes that aerosol, and where you put a medication in that and they can just breathe. We call it a breathing treatment, and that. Back in the day when I was practicing a while ago, that was a little bit complicated to get a patient a nebulizer machine. I had to call a third party, and they had to deliver it and set it up at the house and show the mom or dad how to use it. And it's much more complicated back then than it is today. And this patient kept coming back, and the mom kept saying, well, I'm giving the breathing treatments, but the patient's not, but he's not getting any better. And then when I would give him a breathing treatment, or my staff would in the office, instantly better. And this happened 2 or 3 times. And I quite frankly was a little bit confused. I didn't understand what was going on. And it was my medical assistant who spent some time with the mom and said, show me exactly what you're doing. And what she was doing was she was adding salt water, normal saline, but not mixing it with the actual medication called albuterol. And so she was either confused by the person in her house who kind of showed her how to use it, or that person may have been confused and maybe was new at the job. I don't know. But she wasn't giving the patient any medicine. She thought she was, but in fact, she was just using the diluent, not the actual medicine. Now, why is that relevant to design? Well, because nowadays, those two things are in the same ampule. So it doesn't come with salt water that I have to add the medication and mix it together. Now it's kind of pre-mixed in an ampule. So we've actually made that problem that mom had impossible. It could never happen again because of the way the medication is mixed. So that's not a technology issue. That's a design issue. That was a design flaw, the way that the products were manufactured. And it wasn't evident in our clinic because we do this every day. We're pretty competent at it. But a mom who's never done this before and has no idea about how to do it, it's completely predictable that someone would do this if they didn't understand the directions, or the directions were not given well. And so, yeah, that design principle could have predicted the problem and prevented the problem. And that was a minor problem, of course, but you could imagine something much more serious happening.
Yeah, I think of another guest I had on the show, and we were talking about value-based care, and they were, looking over a lot of readmissions and a lot of ED visits. And a similar problem was the caregiver was there. It was a family, and the child who had asthma was staying at another caregiver. So they did not have access to their plan 2 inhalers. So it was, I mean, these are the things that it's the sense that the challenge, I think, in the healthcare system is to have like boots on the ground. I mean, not like surveillance, but these knowledge gaps that are just so hard. So the short answer of the story is they figured out that the person needs 2 inhalers at 2 different houses, and they solved that. That's a lot cheaper than $34,000 or whatever for the admission. So even though these are totally separate, but it really is intelligence and what's going on with your user. So
Sure.
Anyway, this has been awesome. I'm super glad you came on, Craig. And I believe I saw you're going to be at HIMSS. You're going to be speaking, correct?
I will be. I'll be at HIMSS, and if anyone's going to be there, I think it's in Orlando this year. So yeah, happy to meet up, and If anyone's interested in the book, it's available on Amazon. Just got to put my name in, and you should find it with my co-author. And yeah, happy to talk with you. And I hope that people can take some of the things. I mean, that's really what this is not an academic tome. It's really, hey, these are stuff that makes sense. And if you just think about it and are intentional about applying some of the principles when you're building technology or workflows or a new hospital, I think it'll help.
Well, Dr. Craig Joseph, this has been amazing. And I see this book really, designing for health. The human-centered approach is really almost a starting point to galvanize, kind of getting people like you, like-minded decision makers, healthcare leaders that know that we all know healthcare is broken, but now what are we going to do about it? Let's
Right.
just, and it's a together activity. So,
Yep.
thanks for coming on, and everyone, it's been great for you to tune in to us. I wish you all the best from Planetary Health First.